Przed nami Matt Barrow, który przyjechał do nas z Wielkiej Brytanii i będzie opowiadał i pokazywał, że możliwe jest wdrożenie projektu w takim podejściu w sektorze publicznym w bardzo skomplikowanej materii, jaką jest healthcare, czyli służba zdrowia. No i posłuchajmy. Welcome, Matt.
Thank you. Okay, hi. Two apologies. Firstly, I don't speak Polish as well, so I'll be speaking English. And secondly, the screen here doesn't work for MacBooks, so I'll be looking up here to see where we are. Just a bit more about myself. So I work in England. I live in York in the north of England. Work in London. So I travel Monday, travel home on Friday, spend the week in London. I was out here 2 weeks ago at another conference, at the Agile by Example conference, which was great. Good to meet a lot of people, and I met somebody from the Polish Health Service while we're here, who I'm going to see again tomorrow to talk about similar experiences there. Yeah. So a brief introduction. So we're talking about the National Spine Programme in England, which was a major program, major government program. I was asked by Martin to come and present today because I think there was certainly a lot of concern in the UK going back 5 years or so when we started this, that Agile was something to do if you were developing a mobile phone app or if you were working on a website. It wasn't something to do on a large scale government program. So this was the story about how we did Spine using Agile and how we made Agile work for us. I've been made aware that not everybody is sort of familiar with software development, so I'll try and keep the minimal technical terms, but I'll be happy to answer questions at the end. So what was the National Programme for IT? Back in 2004, the government at the time put together a big programme to connect up all the healthcare systems in England. The idea was that we wanted to have all of the hospitals and doctors and pharmacies all connected together. So if you weren't very well, you went to your doctor, they could send your medication straight to your pharmacy, or the alert for your medication straight to your pharmacy. You can go and collect it, or you wouldn't even have to go to your doctor for repeat medication. You could just go and collect it straight away. The idea was to share information. So if you were taking an ambulance to a hospital, they would be able to look at your information and determine that you're allergic to penicillin or allergic to plasters or something else that would be a problem. And the clinician who was treating you would be made aware of that immediately. And also to do things like future appointment booking. So rather than have to wait for a letter, in England traditionally the process was that you would visit your doctor, the doctor would say you need to go to hospital, and then some weeks later, maybe 4 weeks or 6 weeks later, a letter comes through the post and says your appointment is on the 22nd of January, so I'm busy 22nd of January, so you write back to them, but then they write back 6 weeks later, and so now it's the 31st of March, I can't do that either. So the idea was to have an online booking service that the people could say, well, I want that date and I want the morning and I have that slot in that time. So there were a few things that we wanted to do to join it together. So it was a fairly revolutionary program, and it was big and expensive. It started off at a small number of billions of pounds, so 3 or 4 billions of pounds, and it ended up being almost 13 billion pound. So it sounds amazing, and a real success. You'd think. Well, not so much. There were a number of sort of reviews into the program. A number of people looked at it, and this was a statement from one of the Public Accounts Committee who looked into it. They represent the government on how money's being spent in the UK, what's happening, whether things are correct or not. So I have to read it for those of you that aren't familiar. But this is the biggest IT project in the world, and it's turning into the biggest disaster. And actually, if you look on Wikipedia now, if you Google biggest IT failures, the National Programme for IT, I think is number 2. It might be number 1, but it's certainly quite high up in the list of big failures. Now, there was a number of reasons for that. There were a lot of really good things that happened, but there were some bad things too. It was perceived by many people to not have been successful because the overall outcomes just weren't achieved. Now, it's become a bit of a well-known thing around the world. As I said, attended the Agile by Example a couple of weeks ago, and Gojko gave this a different presentation. He was talking about how Agile works, how government projects work, and how sometimes it can be a major failure. And he referenced this: how long does it take to spend that £12.7 billion by flushing it down the toilet, £120 note at a time? Now we worked it out based on an average flush of 29 seconds. Which gives you just over 3,000 working years for somebody to do it, which is a crazy amount of time. But actually, to put that into context, BT, who were the lead system supplier for Spine 1, actually say that they took over 15,000 man-years of effort to deliver Spine, which is 5 times as long as if they just flushed it away, which is really scary when you consider the context of that, that doesn't include development time. That's just project management. So that's people who manage the process, manage the contracts, the lawyers, the business management things. So this is scary stuff. And when you work out how much that costs based on the average rate as it was at the time for people, they're scary numbers. So Spine 1 was £1 billion. Now, also in the case study that they present on the website, and the case is still available at this Global Services website. So again, you can search for NHS Spine or BT NHS Spine, and it's still available there. They also include this statement that the delivery methodology is now internationally recognised standard for complex program delivery. Now, as we said at the program recently, this was written back in probably 2007, 2008, somewhere around there. And largely what we found now is for major program delivery, this just doesn't work. So, to correct it, the waterfall approach just is now avoided on major programs. So I now work for the Home Office, the English or UK Home Office, working on visas and immigrations. Again, we're working on a very agile program. And we found that when you try and do a very, very large scale agile program, you can work through it in stages. You can think about the things you're doing at each point. When we try and do it as a waterfall program, you spend 2 years of a 10-year program just thinking about requirements. And by the time you've then started to build those requirements, you're 2, 3, 4, 5 years down the line. So by the time you realise those requirements, you get them into live, things have changed. People who 5 years ago wanted to have Windows XP support are now using Windows 10. People who didn't have a smartphone or a tablet, we saw the presentation earlier about older people getting tablets. Well, that just wasn't a thing 5 years ago in England. So in 5 years' time, maybe all old people will have tablets. So that becomes then the preferred mechanism for doing it over call centres and other things. So we now look at waterfall much more. We think about how we can do things in a more iterative way in the UK. We look at that, and we're starting to get a lot more, momentum behind it. A lot of people are backing this at the government level now. So the other things are in there. I mean, there are some big important numbers that came out of the case study. In particular, the 1.3 million staff. It's a big number, and 99.99% available. So this was a very high availability figures. We have people going to hospital all around the time. What we find is the busiest times for hospitals are when everybody else is closed. So Christmas time, New Year's Eve, times when people get drunk, fall over, crash their cars, those sorts of things. They're the busy times. So we can't be unavailable for those times. It's not a 9 to 5 operation. 899,000 registered users, so that there are about 400,000 users that don't actively use the system but are reliant on the system. So the first problem we had with Spine 1 was that the release cadence when we started off, so the rate at which we were putting releases out, was designed to be every 3 months. Now for waterfall projects, that was seen as pretty fast. That was quick, and the idea was to do relatively small things every 3 months. I should stress this is still Spine 1 that we're talking about here, not Spine 2 that I worked on. But for Spine 1, it started at 3 months, but being an IT project, an IT software delivery project, the natural thing happened, and 3 months very quickly became 6 months. Things slipped, things fell backwards. But then the government got nervous, and the authority got nervous. Well, why are things taking 6 months when we said they would take 3 months? So we need to put more assurance around things. We need to work out what's going on. So let's put a whole load of extra managers in place to work out why things are taking so long. Which then, of course, meant that it took 12 months or greater than 12 months to do anything, because everything had to go through extra processes, extra checks before it would go to production. And then, of course, what happens was when you work out the cost of a release, releases get so expensive, because if you're releasing once every 3 months, it's okay, it's not too bad. If you're releasing once every 12 months, then things like a release manager or a transition manager, the jobs that are associated just with putting a release into live, you're only doing one of those a year. So you're paying somebody 40, 50, 60,000 pounds a year to do one release. So the cost of a release becomes very expensive. And in that case becomes prohibitively expensive. So you end up never releasing any code because it's always too expensive. And this led to an interesting problem, which is known as the gold-plated iPad problem. So we had a small team in Southport known as the National Back Office. Now the National Back Office do things like they look at like patient records. So if somebody says my patient record's wrong, my date of birth's wrong, I need to correct it. There's a back office system that deal with that. Now this organisation have about 30 or 40 users, and they use one system. But what we found was that to make a change to that system would cost tens of thousands of pounds per user. So so it became the case that actually it's cheaper just to keep them happy, just to give them gold-plated iPads, and that's better than fixing the system for them, which was a real quote we had from the supplier. The second problem, of course, was how you support the service. So live support was a real problem. Yeah, BT weren't just on their own in delivering Spine. They had all these other suppliers that worked with them. Some of the names you'll be familiar with. Oracle in particular was a big supplier. Logica and Mastech were two of the key system suppliers that provide the applications. And of course, for all of those, you've got all of the normal people that you would have on a support shift. So anybody who's doing app support or network management or the sorts of things you require to keep the service going. But of course, each of those roles covered. So you end up with a sort of a duplication of roles across the organisation. Then when you add on that it was a government project, so we had to have assurance, and so double a number of the roles again, and had assurance overhead on top of that. It becomes crazy. So we ended up with 150 people on shift, sort of around the clock, 365 days a year, which was bizarre. Really crazy numbers. And this was supporting a relatively large application, but at huge cost. So Spine 1, that's what it was. That was the challenge we faced. Largely the system worked very well doing the day-to-day operations. It was expensive. It was expensive to manage, expensive to run, but it did a good job. It served a good purpose. It became critical for end users, and largely it was sort of the most successful part of the original National Programme for IT contract. So for Spine 2, we thought about this again. We thought about what we were going to do, what were the problems, what were the challenges. We knew we had to replace it. We knew that going out to a big systems integrator would be prohibitively expensive, be expecting maybe another £1 billion or something like that again for Spine 2. And we also thought that the market's changed. So in the UK at the time, there was a bit of a shift towards doing Agile, a bit of a shift towards open source technologies, towards using small and medium enterprises rather than big systems integrators. So we took a different approach. We said, well, we'd like to try Agile for this. So we started talking to the sort of senior managers around the organisation, the directors, the people who were sort of key stakeholders and our senior responsible officers about what they wanted from Spine, and they came up with some of these options. My favourite was this top one, which was that we wanted to be like for like but better. So it had to be exactly the same as the existing system, but just better. So quite a challenge. The cheaper is an interesting one. We weren't looking to be 2 or 3% cheaper. We wanted to be orders of magnitude cheaper. So 100 times cheaper or 10 times cheaper, but 10 times as fast as well. There was a number of things we had to do, like resilience and scalability, safety, things you can't really get away. You have to have patient safety. You have to have safety of your data, of your systems. You can't have any integrity problems. And we didn't want it to be seen that by doing Agile or by using open source, we were going to be using software that had been delivered in a back bedroom of somebody's house and was a bit ropey. So we started off with the waterfall versus Agile discussion. We considered what was going to be best. We'd put forward the idea of doing Agile. Traditionally, we'd always done waterfall. We thought that Agile was going to be a little bit different in this case. There were some good reasons to do Agile. So complex interfaces is one. We knew that there are about 750 different messages in or out of Spine. So things like find a patient, update a patient, create a medicine, these sorts of things. Each of those is an individual interaction. There are about 750 of those. Most of them are poorly defined, and they're defined in such a way that it sort of works as it is, but nobody really knows why it works. So people develop to the system rather than developing to the specifications. We had the government mandate, so there was a big push from government at the time to say, you ought to do more Agile. Agile's the way to go in future. So that was behind us. Evolving requirements we knew were going to be the case. So we had things were coming through like child protection and other sort of scenarios where we knew that things were changing over time. We knew that the government was likely to change during the course of the programme, which it did, and we were expecting them to be cases where there may be new priorities. We may end up with a different route that we need to go down. And the existing this 100,000 or greater than 100,000 pages of specification was something we heard from the original supplier, from BT. They told us there was a greater than 100,000 pages. When we looked into it, it was mostly wrong. Not because it was written to be wrong, but because it was written at a time when it was first designed, and then things changed over time, and nobody ever updated the documentation. But there were a number of reasons not to do Agile as well. So organizational perceptions. It was seen at the time that Agile was very much a way to not do documentation or to cut corners or to just get away with doing things that you wouldn't normally do. the minimum viable product, the smallest system that we could have put live and actually been useful to the end user was 90% of the total solution. So it wasn't that we could have a few weeks of development, put something live, then do a few more weeks, put something else live. It was a really case that we had to work for 3 years and then put everything we developed live at that point. And user consistency. There's again a common quote that we hear, that if you ask 5 doctors for their opinion on something, you get 7 different answers back. And this is a real problem, that you can't get the same answer from different people. We find that some hospitals want something is very important to them, other hospitals want something completely different. And the existing processes was something that we had to battle against. So within the organisation I was working with, the National Health Service, there were all sorts of processes for how we put systems into live, processes for assuring it, for testing it, for making sure it was clinically safe. Everything had a process, and then some of those processes had 2 or 3 processes sat below them. So there was a lot of stuff we couldn't just cut through it and work around it. So we ended up having talked to the likes of ThoughtWorks and some other big sort of agile protagonists. We ended up with a kind of hybrid model. So we called it agile with a small a rather than a capital A. We weren't pure agile. We weren't releasing every week. We weren't doing the things that a pure agile agency would advocate. But we were doing things in a much better way than they had done before. We were taking the bits that we could do to work for us. So for example, our first release was after 3 years. As I say, we couldn't really release anything any sooner. But then our subsequent releases were every 3 months. And actually, during the first 3 months of operation, we were releasing pretty much every day. We were putting code fixes, bug fixes, minor enhancements out to live every day. So we were fast with our change. The testing was fully automated, so we had in total about 25,000 automated tests across the system, and they ran on a continuous integration pack that took about 2 hours. So we can make a change, and within 2 hours we had pretty much absolute confidence that everything worked. But again, slightly different to usual, we took an upside down pyramid. So the normal test approach is to have lots of unit tests, lots of low-level tests, then fewer system tests, and then very few integration tests. We knew that integration was our big risk, so we turned that upside down and focused very heavily on integration testing. We took operational simplicity over developer complexity. This was quite a challenging problem. Again, what people will often advocate is to just write something, get it live, and then refactor it or clean it up later. For us, we went the other way around. We thought that if somebody was going to get called at 3 o'clock in the morning to look at a problem or to fix a bug, it was much better that it was easy for them to fix it than the person who had been working in normal hours in the lead up to it. So we focused very heavily on making sure the code was good quality. It was simple to follow, simple to understand, and then easy to fix when something went wrong. Linked to that, we then looked at architecture and infrastructure. This was something that at the Home Office, with the project I work on now, they didn't do. They let infrastructure be, I guess, evolving as they went along. And by not tying it down at the start, they've ended up with a very, very complicated architecture. So for Spine, we took a very simple architecture. We had effectively 1 or 2 core technologies. We focused on those technologies, and then we built around that. And what we found now with some of the evolving architecture models is that you end up having to make compromises down the line to try and get things working together again. The external processes I commented on earlier, we knew that we weren't going to be able to remove them. We couldn't do anything about them. So we focused instead on improving them. So the assurance organisation, for example, that used to make sure the systems were ready to go live, we explained to them they weren't going to be able to work fast enough. Typically, they would test for 6 weeks before a production release was ready to go live. We explained that in a 2-hour go live window, they just couldn't do that. So we asked them instead to look at our processes, look at how we did things, look at our automated test pack, and make sure they were happy with how we went through to get to live. And that then allowed us to be in a position where instead of assuring every individual release, they assured how we work as a team, and then the individual releases could just go live. And the final point on here was the fully automated build and configure. So right the way from development through to live, it's all fully automated, so that you don't have any concerns about missing a step out or doing something wrong or slight inconsistencies between different systems. Again, back with Spine 1, there was a release that went wrong, which was reportedly because one of the pages of the instructions were stuck together, and the developer was following the instructions, turned 2 pages over, and missed a whole page of instructions out of about a 300-page document. So we didn't want any of that in Spine 2. Some other things we had then, so self-documenting code. As I mentioned before, the 100,000 plus lines of code, lines of documentation that we had in the pages documentation, that we had in Spine 1. We didn't want that. We didn't want to have lots and lots and lots of documentation. So the core things, the key things we documented, so things like the architectural principles, the key operating procedures, key design decisions, things that were important to us, that we'd had to, or why we thought about something that wouldn't be immediately obvious by looking at the code, the rationale behind some decisions, we put that into documents. But otherwise it's all self-documenting. So each section of code has a small explanation above it. So again, if you're following through the code, you can understand what that snippet is doing. And that forms part of the code review criteria. We went for four weekly sprints and 3 sprint releases. So we had every 3 months we put a release out to live. In the first 3 years we just put it out to effectively a staging environment. We didn't put it all the way to live, but subsequently we put everything out to live. So the 4 week sprints work quite nicely for us because we're a relatively large team. Or for development size, it's a relatively large team. We have to get lots of feedback. There is still some testing that comes through the process. There is still some clinical safety sign off. So having 2 week sprints or 3 week sprints would be challenging for us to get things out the door. Scrum-ish and Kanban-ish. We started off being, as I say, not true Scrum. You know, we took the best bits of it. We didn't do everything, but we started off following Scrum largely. Post live, we then some of the teams switched to Kanban just to work through defects and issues. It didn't make sense to try and plan things into a Scrum process. It made more sense just to put things on a board and you work through them and just manage what you've got in process. And then we use things like Jira, Confluence and Jenkins, which are fairly standard now. We did also have physical card walls as we wanted to. It was a nice thing to be able to stand around and talk around in our stand-ups each day. So some other final points then. A small team, we did have the Brooks Law quote, which those of you who aren't familiar, the idea that if one woman can give birth to a baby in 9 months, then 9 women should be able to give birth in 1 month. We did have this on the program, and our senior managers wanted to, as soon as we looked like we were going to go late, they wanted to have many more people. We explained that wasn't going to help things, it was going to slow things down. So we made sure that at no point we went over 35 engineers. That was our limit. And they were all multidisciplined, so we didn't have people that were just testers or just developers or just business analysts. Everybody could do a bit of everything. That made the recruitment hard. It was difficult to find people that were genuinely able to fill those roles, but it made life a lot easier in the long run to support the system. We had a flat organisation, so I was one of the heads of the program, but I was still involved in developing and testing. You know, I made sure that there wasn't a case there where it was a hierarchy, and you talk to you and you talk to you and so on all the way through the train. It was just a case of I was there, I was working with the team, I was hands-on developing myself, getting involved in the discussions in the meetings, and that was the same for everybody who worked in the team. It was very very clear, very non-hierarchical. We had a belief and commitment to doing it right. You know, we had this concept that everybody in the UK knows somebody who uses the NHS in some way, either family members or close relatives or them themselves. You know, I use the NHS. So getting it right was important. You know, all of our records for the people that work on the program were all in the system. So we didn't want it to be something that was a bit flaky. Further to that, of course, then we had a DevOps capability where the developers were also the people that operated the service. So if they did it wrong, then typically they would get called out in the middle of the night to fix it again. So that was a strong driver. And the Muppet concept, we had a very clear definition of done, and that included things like code review. We had to have tests in place. We had to not break the master build or the developed build when you check things back in. And for anybody that did break the bill, we had a Muppet which was put on their desk, so about this big, and it was a very clear indication that they'd done something wrong or they'd broken the build. It was a bit of fun, but at the same time it was quite a clear, that wasn't good, and they had to have it on the desk until the next person broke something, which actually tend to be fairly frequent. And so the result, to go back to the Spine 1 numbers that we had on there, and then compare that with Spine 2. Spine 1, 15,000 man years to develop. Spine 2 was less than 100 by comparison. So we team of 35, less than 3 years, and actually a team of maximum of 35. We don't know what the actual number was, and it depends how you count it, but we know that it was less than 100. Spine 2, hours to plan and minutes to execute. It really is simple now. It's as simple as pressing a button on Jenkins to click go, and it pushes the release out to live. We've probably done in the year and a bit since we've been live. We must have done 400 or 500 releases in that time to the 2 sites. So there haven't been any problems as far as I'm aware. We've had to roll back maybe 1 or 2, but it's been a very easy process. and does take literally minutes to execute. 3,000 servers for Spine 1 and specialist appliances. So there were specialist tools and specialist hardware that were very expensive to maintain and support. For Spine 2, we use less than 100 servers, and it's all commodity hardware. So what that means is it's hardware you can buy in any shop. We don't need specialist support for those. It's just standard off-the-shelf kit. And that means that you can then, if you have a hard drive failure, you can leave it until the next day, replace it. It's no problem. Spine 1 was the 150-man support team, as I mentioned. Most of those were on site around the clock. For Spine 2, we had 3 to 5 people, and 3 of those are on site. The other 2 are off-site developers who are asleep or doing what they want. They get called if something goes wrong and we need escalation. Most things just wait till the next business day, so normally we don't ever go above that 3. And the specialists, we went to generalists. So for Spine 1, you would have somebody who looked just at the demographics, so the things about the person, or just the prescriptions, or just the clinical domains. You would have specialists for each of those, specialists for networks, for hardware, for all the different things. For Spine 2, we got rid of all that, and anybody can support any of the different systems. And so there were some other benefits as well. The 99.9% reduction in release cost. This is sort of ongoing release cost. It varies, release to release. Some of them are very small, they cost nothing. Some of them are still quite large. Platform for change. This was one of the things where I mentioned before that because of the cost of Spine 1 getting so big to put any change live, it became very difficult for anybody to justify something going in. The business case was too difficult to get through. For Spine 2, we now have the ability to just put something live, see if it works for a few days, take it back out again, or change it, or make a further enhancement. It's easy to do. 99.99% available. It's more 9s than this, but we weren't sure exactly how many. This was our target, and we've exceeded that. I think it was 6 9s that we'd achieved. And we're failure tolerant. So when things do go wrong, when we have a server fail or a hard drive fail or something else, the system is designed just to work around that. It doesn't require an immediate reaction. So we fix it whenever we're next in the office. So if it happens on a Friday night, we'll fix it on Monday. It's no problem. We've got the resilience and the tolerance in there. So at 2,000 messages or greater than 2,000 messages per second, and they're running now 90% faster. This translates exactly into a 750 working day saving for the NHS, and that's every day. So every day we save the NHS 750 days of time, which is pretty important to us. So year 1 saving was calculated. This is just on development costs. This doesn't include the 750 day saving for the NHS, but just in development costs and running costs compared to Spine 1 was 21 million, and that included our development. We expect year 2 and 3 and 4 to be much greater. Now 21 million is it's a big number, but it's not that big a number in the terms of the grand scheme of the NHS and how much the NHS spends on things. So we like to think of it in terms of quality adjusted life years. Now the quality adjusted life year is something that we use in the UK to determine how effective a medication is. So if we buy a medication for somebody, if a new cancer drug is released or a new drug for something else is released, we calculate the value of that drug as to A times B, where A is the number of years of life gained, and B is the quality of that life, where 1 is full health and 0 is death. So if you get 2 years of full health, that's 2 quality adjusted life years. 2 years of half health, how half health would be measured, would be 1 quality adjusted life year. And what the National Institute for Clinical Excellence say at the moment is that 20 to 30,000 pounds is what 1 quality adjusted life year is worth. So if a drug costs 25,000 pounds and gives 1 quality adjusted life year, they will normally say that's fit for purpose. That's a good thing to buy. That's due to be reduced down to 13,000 based on a recent report. So when we go back to the numbers and turn that into quality adjusted life years, it results in 1,615 quality adjusted life years just in the first year alone. So that's 1,615 people we can keep alive at full health for an extra year by running Spine 2 over Spine 1. And in particular, what that means to us as developers and engineers who worked on the program is that's more than 46 per person. So we can each say, well, that's 46 people that we've helped keep alive at full health for another year, or 92 at half health. So a great result for us. What went wrong? I'm just about out of time, and what went wrong is probably a presentation on its own. There was all sorts that went wrong. We got our estimations wrong. We thought about things the wrong way. When we started off, Martin, the technical lead, and I were working maybe 100 hours a week every week. So all our projections for how long things were going to take were based on everybody working 100 hours a week, which of course didn't happen. Everybody else came in and said, well, I work 40 hours a week, so everything took longer. We had some problems with technology. We had some technical challenges. There were lots of things we learned, but we did learn a lot of things from it. And then we've gone forward to help other programs with that. As I say, tomorrow I'm meeting with the Polish Health Service to talk to them about some of this in more detail and share some of our learnings with them. And so that's it. If there's any questions offline, I'll take the questions now as well, but anybody wants to email, feel free. And questions.
Thank you very much, Pat.